Greetings, everyone. Welcome to the 233rd session of the online Optom Learning Series, OOLS. And today's session, we have with us Katie Harrop. Katie is a qualified optometrist. She has a vast experience working in the private practice for a number of years, where she fitted patients with contact lenses. She joined the contact lens industry in 2005 as a professional service manager for Number 7 Contact Lenses, which is a UK-based specialty contact lens laboratory. Recently, in the year 2023, she was appointed as senior manager for global professional education in CooperVision's Global Professional Affairs team. She has been in the industry where she has done a lot of educational events. She has trained optometrists and widely lectured on contact lens related subjects on myopia control, orthokeratology, rigid corneal lenses, scleral lenses, hybrid lenses, and fitting patients with irregular corneas. She had also provided various CE lectures to the undergraduate programs as well as the optometrists in the UK as well as globally. She's a former BCLA Council member and holds prestigious fellowships from the British Contact Lens Association and also fellowship from the IACL. So welcome, Katie. Thank you so much for joining us on this Sunday afternoon in the UK. And I'm just going to leave the screen time to you, please.
Fantastic. Thank you. First of all, I'd just like to thank you for the invitation to speak to OOLS. It's harder to say that than you might imagine, today on the subject of return of the myope. So you heard a little bit about me in the introduction, but really my journey with myopia and myopia control specifically goes back to my time in practice. So back in practice, I was fitting orthokeratology. And like many people, I began to notice that young myopes didn't progress when wearing orthokeratology lenses. And then if you go back to 2005, that was when we saw that first paper looking at that slowing of the progression of myopia in a clinical study setting. So myopia has become my passion alongside orthokeratology, and hopefully I'll be able to share some of that with you today. So we have a busy agenda for the next sort of 45, 50 minutes. I'm going to start by setting the scene, so the myopia landscape, and then we'll go on to spend the majority of our time looking at a number of scenarios for patients who are returning to the practice after already having a prescription for myopia. So you'll see as we go through that some of those are in myopia management or myopia control corrections, and some of them are not. Once we've gone through those scenarios, we'll then think about the exit strategy. So how we move our patients from myopia management through into adult vision correction. We're going to summarize, and then at the end, we do have an opportunity for Q&A. So let's begin with the myopia landscape. So there have been a number of surveys carried out by the Institute of Myopia, International Myopia Institute, looking at our prescribing habits for myopia control. And they carried out those studies between in 2016, in 2019, and in 2022. And I believe that the current survey is currently open. So if you visited the IMI website, you may well find that you're able to contribute to that prescribing data for the latest version. So this slide shows in particular the European data, but you will also find this for different parts of the world because I know that we have an international audience today. But what I want to do is look at this European data because it's very easy to pick out the points in here when certain interventions became available. So let's start first of all by having a look at the spectacles section. So that's our section over on the left. The royal blue colour is your 2016 information. The turquoise is the 2019, sorry, and 2022, the most recent data, is in the grey colour. So you can see in that spectacles section that the largest number of lenses that have been fitted, interventions that have been fitted, single vision is our most prescribed correction option for our young progressing myopes. So I'll just let that sink in for a second. That's single vision across the years 2016 all the way through till 2022. All the way through, there's been a little bit of dabbling in bifocals or standard progressive lenses, but it isn't until late 2020 that we see the introduction of specific myopia control spectacles to the market in Europe. So that's where we see that grey bar for myopia control spectacles appear. You can see it also relates to a reduction in single vision spectacles. So that's good news. We're starting to move into the myopia control area in spectacles. If we have a look at the contact lens data, you can see that, again, there's some prescribing of rigid corneal lenses for myopia control, or just for young myopes in general. We know that the evidence for this is not particularly strong, so it may be that those rigid lenses have been prescribed for other reasons. We have a significant number of patients being fitted in soft single vision lenses, some soft multifocals, and you can see again that there was that introduction of soft multifocal contact lenses, and with MySight being introduced back in 2017, and you can see that the prescribing of those soft myopia control lenses is increasing. Orthokeratology has been in there and stayed in there in the mix, which I'm pleased to see. But what I'd like to highlight, I think, here in terms of contact lenses is the fact that there is plenty of contact lens prescribing happening in young myopes. If you added together the single vision and the soft myopia control bars, you would find a really good number of patients in soft contact lenses. What is unfortunate, I think, is that the soft single vision lenses actually still outstrip the fitting of soft myopia control lenses all the way through until the most recent study, so until 2022. We've always been worried that there's a concern around young children being fitted with contact lenses, and we know from a lot of the data that children get really great benefits from being contact lens wearers. And it seems that actually practitioners are really happy with the benefits of being a contact lens wearer, but maybe they are taking their time shifting into soft myopia control lenses. So just have a think about how that's reflected in your own practice, and we'll see whether there are opportunities as we go through. You'll also see that there's some dabbling in pharma, and I think in Europe that's probably mainly atropine. Depending on where you are in the world, optometrists' access to atropine really varies. So there will be some countries where it's routine for an optometrist to be able to prescribe atropine, but across much of Europe that's not the case, and that's probably why we're seeing very little use in pharma. We also see that there's a bar in 2022 for combination therapies, so that is most likely to be atropine combined with one of the other interventions. So that could be with myopia control spectacles, it could be with soft myopia control options, or even with ortho-K. So again, that's something that we'll continue to watch as these surveys continue to come in. But looking at that data, what is the most prescribed option for myopia? Quite frankly, it's the one that doesn't work. It's the one that has no evidence to show that it's slowing the progression of myopia, and that's single vision spectacles. So that means that when we see myopes for follow-up, the most likely intervention that you're likely to see them in is single vision spectacles. And is that what we should be doing? Is that what our professional bodies believe we should be doing? Is that what our patients believe we should be doing? Well, I think increasingly the answer to that question is no. If we go back to 2021, the World Council of Optometry passed a resolution advising optometrists to incorporate a standard of care for myopia management into their practice. So this was a really big statement that optometry should be doing more for our young progressing myopes. Many of your international and local bodies have endorsed this standard of care and therefore changed their guidance and updated it to reflect myopia management being part of a standard of care. And you'll see a couple of examples of that in the next couple of slides. But you as an individual can also take a pledge to endorse that standard of care. So you can take a pledge to show that you are incorporating myopia management into your practice. The WCO currently has just under 70,000 individual pledges, and they aim to get that to over 100,000 by the end of the year. So you can follow this QR code on screen and take a pledge. And once you've taken that pledge, you'll be given access to a number of resources which you can share on your own social media to show that you've taken the pledge to incorporate that standard of care. So that can be really reassuring for your patients, and also help spread the word about myopia management in the profession if you use something like LinkedIn. So I would really encourage you to follow that QR code. I've made it my mission to make sure that as many people as possible sign up over this year. For a couple of examples, this is the one most close to me because it's a UK organisation, the British College of Optometrists. They updated their guidance back in 2022, so just a couple of years ago. They had already had some information on there, but they really expanded on that, particularly to show that if myopia management is within your scope of practice, then at this point you should be making sure that you keep up to date with evidence, which can be challenging because it's a fast-moving field. So this is where it's fantastic to use people like the OOLS to help you with keeping up to date with the evidence, allowing speakers such as myself to come along and give you the latest information. You should also be able to discuss options with the patients, explain both the short and long-term benefits, also very importantly how to manage expectations. You have to remember that this is very, very new for our patients, and therefore they may have the expectation that any intervention is going to stop myopia progressing completely. And we need to make sure that they know that that isn't necessarily the case. And you'll see that as we go through the scenarios. They also ask us to consider how we'll monitor progressing myopes and make sure that we keep records accurately. But what I think is very interesting is that they added in a section this time about optometrists who do not have myopia management within their scope of practice. So this might be that they work for an employer who doesn't have that set up for them, they don't have the right equipment, they don't have the right skill set. And what it does is it really says that you should be able to make sure you have conversations around myopia management, and where appropriate, refer to a local colleague. And therefore, this is hopefully going to increase patients' access to myopia management options. In 2022, the Association of British Dispensing Opticians also updated their position on myopia management, understanding that dispensing opticians also have a responsibility within this field, particularly with the introduction of those spectacle lenses for myopia management. But it's also important that our dispensing colleagues understand the full range or full portfolio that we have available to us, so that they can also support patients through their choices. For example, if a spectacle lens becomes no longer suitable, they know about contact lens interventions. So we are very happily in a position where there's increasing availability of evidence-based interventions. The first one being lifestyle advice, and this is something that we can very simply apply to all our paediatric patients, whether they're myopic at that point or not. And that's really to let them know that spending time outside is protective against development of myopia. Personally, I've always thought this is particularly relevant to those parents who come in for their own eye examination, maybe those ones with a baby in a carry car seat, or maybe the ones whose children are quietly playing on an iPad in the chair while their parents have their eye exam. It's a really great opportunity to talk to them about getting their children outside, ideally a couple of hours a day. And we know that in many parts of the world that can be challenging. You could be in Norway, for example, and find that much of the year is cold and dark, and therefore it's hard to get outside and get that daylight. Or you could be in a very, very hot country where spending time outside again is challenging simply because of the heat. So we know that this isn't always easy, but it's good advice to give parents so that they can try to incorporate that in their day, and ideally choose activities for their children that are outside. Now, also, there's much advice around about reducing the amount of time that children spend on devices. My view is that if you're outside, you're much less likely to be on a device. So rather than what can sometimes seem to be an increasingly difficult thing to tell your children to put a device down, replace it with an outside activity. I know that if I told my children, who are 13 and 15, by the way, to stop being on a device and they put it down, they wouldn't know what else to do instead. So I think it's probably a good idea to have something outdoors lined up for them. We've seen a lot of myopia controlling spectacle lenses enter the market over recent years. And here we have three of the main technologies highlighted. But actually, again, depending on where in the world you are, you may have one, all three, or even many more lenses available to you. But in certain parts of the world, you're yet to get these and are desperately waiting for these to be available in your market. The US being one of the areas that comes to mind, because they have Canada to the north that has all of the options available to them, and yet they are still waiting on these spectacle lenses. But where they are used in the world, they're very popular and maybe provide a great entry point into myopia control. Myopia controlling contact lenses. So actually, parts of Asia have had these lenses available for far longer than the Americas or EMEA or Europe, for example. The dual focus soft contact lenses include MySight one-day contact lens. There are also extended depth of focus lenses. So those two are your kind of soft lens options. And then you have orthokeratology. And as I said earlier, it's almost that the myopia control effect of orthokeratology was just a convenient accident or convenient side effect of its vision correction and lens-free optics during the day. But there's a really healthy evidence base for orthokeratology as a myopia controlling lens. So that set the scene of the landscape that we're all working with, and I'm very aware this is a international audience. So what I'm trying to do here with the scenarios that we'll go on to now is really look at the kind of groupings that we can apply. So the patients that have had an intervention of sort, or maybe the patient that has not had an intervention at all. So when you think about patients that are myopic that will be coming into your practice, they'll broadly fall into one of these three scenarios. You have the child who has been prescribed myopia controlling spectacles. So this is a patient who and whose parents have decided to follow your advice and has chosen spectacles as the lens of choice. Then we have the child who has myopia controlling contact lenses. We also have the one that got away. What we're going to do in this section is actually group together the first two and deal with the one that got away separately. And what we're not going to think about here it is maybe the patient who is in single vision contact lenses, but we can also sort of include those in the one that got away as well. I just wanted to think about the follow-up schedule before we go into the specific scenarios. So this is taken from a combination of the IMI clinical guidelines report that was published in 2019. And this laid out some recommendations for follow-up for patients in a myopia control intervention. So that's the sort of middle two columns. And then on the right-hand side, we've got the College of Optometrists frequency of eye exams advice. Again, this may vary in terms of the recommendations for young progressing myopes in your country, but apply this as you feel is suitable. That might be limited by reimbursement, for example, by an insurance company or by the government, or how much the government will pay a practice, or how frequently a government will pay a practice to carry out an eye examination for children in this age group. So if we were to look at this, we must remember that actually those follow-up Schedule 1 appointments for the myopia controlling spectacles and for the myopia controlling contact lenses are not about looking at progression. They're very much looking about how the patient is settling in and adapting to that intervention. So if you look at the myopia controlling spectacles option, if you see a patient at 2 weeks for a follow-up, that's most likely to be followed up with a dispensing optician or equivalent. And it's about making sure that the spectacles are fitting well, the patient is adapting to the vision, and that everything is going as it should be. For the myopia controlling contact lenses, those 4 to 7 days, and actually including that 1 month appointment, are again about adaptation. They're about making sure that the patient is handling the lenses well, that the eye is happy, and that everything is proceeding as it should be. So in this scenario setting, we're actually not going to be covering those appointments. We're going to assume that everything has gone well in those sections, and we're going to be looking at the 6-month appointments. So we're going to be looking at that across the myopia controlling specs, myopia controlling contact lenses, and that single vision correction. So let's group these myopia controlling options together and look at a scenario that works there. So what are the non-modifiable risk factors for all of these patients? Younger age, especially under 10. So the younger you are when you're diagnosed with myopia, the more likely you are to progress rapidly. And also, if you are still younger at follow-up, that's still the case. Faster progression in the prior year, particularly if it's more than 1.25 diopters in the year. If you have higher myopia at the commencement of myopia control treatment, again, that's a non-modifiable risk for faster progression. And also having 2 parents that are myopic. So if you are unfortunate to have 2 myopic parents who bring in their myopic child, you really are going to have to watch that child very carefully for rapid progression. Thinking about what average annual progression we're likely to see, we've already discussed the fact that younger patients are likely to progress more rapidly. So our bottom bars here are our youngest patients, so younger than the age of 9. And their progression over a year is likely to be around 125-ish. 9 to 11, we're looking just somewhere between 0.75 and 1 diopter. And at age 12 to 16, you can see that that's slowed quite rapidly. And that's our sort of pinkish red hashed bars. So that's our normal progression without any intervention. In this graph, we're assuming control of progression of around 50% with any of these interventions. And so you can see what an impact that makes on the progression of each child. So let's think about scenario 1. So I would like to introduce you to Mia. Mia is 8 at the time of presentation. So this is back in November 23, so about 6 months ago. She had no family history of myopia. So although we've talked about the fact that young people and children are more likely to be diagnosed with myopia if they do have a family history of myopia, it's still not uncommon to see patients who have no family history of myopia. It's her first eye examination at age 8. And the reason that she's come in is because she was struggling to see the board at school. So she was struggling to see distance things. She does gymnastics and a drama club 1 hour per week each. And at the age of 8, her prescription is -1 right and left. So a nice, straightforward myopic prescription. At this point, the options were explained to her, and her optometrist made a recommendation for myopia control. And at that point, she was prescribed myopia control intervention. And there we go. There's just our reminder of our non-modifiable risk factors. So she doesn't have 2 parents that are myopic. She doesn't have a high prescription at the time of diagnosis, but she is under the age of 10, so she's likely to progress more rapidly. And we know that actually we don't know her history. We don't know how quickly she became -1 because this is her first eye examination. So she's now come back in. It's May 2024, which it is. And she's come back in, and we're going to do some standard questions, history and symptoms, and assessments to see how she's getting on with her myopia control option. So we're going to cover wearing time. So that could be with her myopia controlling spectacles, or it could be with her myopia controlling contact lenses. We all know from seeing adults for many years that if you say how many hours a day do you wear your lenses, quite often they come up with a random answer. or maybe potentially the answer that they think that they want you want to hear. So I'd really encourage you at this point to maybe take the approach of saying, what time do you normally put your contact lenses in, or what time do you normally start wearing your glasses? And then to say, what time do you normally take your contact lenses out? Or in the case of myopia controlling spectacles, you can ask questions that follow the lines of, do you wear your glasses all day? Do you take them out when you're at home? Do you take them out for, take them off when you're at home? Do you take them off for sporting activities? Do you wear them differently at the weekends than you do in the weekdays? I think in spectacles, it's really important to consider this, particularly with your low myopes. And I'm saying this from the background of being an optometrist who is a low myope herself. And I am very much the put specs on when you need them rather than wear them all day, which is absolutely fine for me as an adult. But actually, if we've got a child in myopia controlling spectacles, even at -1, like I am, we would really want them wearing them full time for reasons that we'll talk about later. So thinking about how you ask those questions is as important as asking them in the first place. What we also want to do is ask them about their vision. So are they noticing any changes in their distance vision? How do they find vision when they're reading? If it's contact lenses, we want to talk to them as well about the comfort with the contact lenses. So we want to ask questions that will help us establish whether the correction option is suitable for the patient at this time. We want, with contact lenses, also to think about handling. So we want to make sure that they're not having any problems with the application or removal. And with spectacles, we absolutely want to make sure that these spectacles are fitting well. So again, I'm sure we've all seen patients who leave the practice wearing a beautifully adjusted pair of spectacles and come back a few months later with them halfway down their nose, or extremely wonky because the sides have become damaged, and also some very strange angles on the front, so sometimes lenses tipping out. And this is because young children are active and sometimes those spectacles just need adjusting. But also thinking about things like, are they really grubby? You know, do they need some instruction on how to clean those spectacles? Are they scratched? Do they remember to put them in their case when they're not wearing them, which, as we've just pointed out, should really be only when they're in bed. So Mia has come back in for her 6-month checkup. We've done all of those discussions and assessments, and we're finding that at this point she's -125 right and left. So we're going to move on to our first poll question, which is, what is your clinical management of this case? So she's progressed 0.25 right and left, and your options are staying with the current myopia control intervention, no update to the prescription, stay with the current option but update the prescription, or change the myopia control intervention and update the prescription. So if you'd like to start voting, that would be great. And we're getting plenty of options coming in here. I'll wait until that stabilizes a little.
Yeah, so the answers are coming in and I've launched a poll. So probably give another 10 seconds for everybody to kind of put in their thoughts. Yeah.
Yeah, excellent. There's 50% of you have participated so far. So the rest of you, you're going to have to commit. But the great thing is nobody knows what you said.
That's right. Yeah.
It's brilliant. We're sitting fairly stable now. No questions coming, responses coming in. So I think it's probably a good point at this time to end the poll and sharing the results. So we can see that the most popular answer here, with just under 60% of responses, was stay with the myopia control intervention and update the prescription. 28% would suggest changing the intervention and updating the prescription, and 14% would stay with the current myopia control intervention with no update. So thank you very much for participating in the poll. We'll move back to the slides. Hopefully that will go smoothly. So I think actually if you look at those answers, pretty much all of them are acceptable answers. if you stay with the current myopia control intervention, if that with no updates to the prescription, if that was your answer, I think actually that's a perfectly reasonable response to this. 025 in 6 months is very much within the range of progression within that controlled bar. It's important to remember, and this may come up again as we go along, that actually we really ought to be considering progression over a period of 12 months, because there are seasonal variations, particularly if you live somewhere where there's extremes in the seasons rather than somewhere where the seasons are much more difficult to establish. But there is a change. Myopia tends to progress more rapidly in the winter than it does in the summer. And this is probably because there's less outside time and less daylight around. So actually, we really ought to be assessing this progression over a full 12-month period rather than a 6-month period. And being within that kind of range, I think it's reasonable to stay with the current intervention. Equally, updating the prescription, but staying with the current myopia control intervention is extremely valid. That's possibly easier to do if they're in a contact lens, because you just order the next set with the extra minus incorporated. Maybe a little bit more challenging in the spectacles if we need to ask for parental contributions to that spectacle change. So again, that might be part of your decision-making process. For those of you that were thinking about changing myopia control interventions and updating the prescription, I would just maybe suggest that there are alternative options before you jump into the myopia control intervention. And maybe we'll look at those in one of the following scenarios. So in my view, this is pretty much on track. So you can use phrases like, and I'm just going to move you out of the way, not that you know you're in the way. I'm pleased to report that Mia's myopia is well controlled. The vision has changed slightly, and the small changes suggest that the myopia is slowing by around half of that we would expect. This is a great result, and we should continue with this treatment. So that's a phrase that you might like to use. We're going to arrange the next follow-up. As we discussed, are we going to change the prescription? I think at this point it is important to think about the wearing time. So that was one of the questions that we were going to ask in the initial assessment before we check the prescription. And this is a great time to reinforce that. We're also going to think about the visual environment. So thinking about the options for making sure that they have a correction that's suitable for that environment. And then we're going to make sure that we revisit the do's and don'ts of contact lenses or spectacles. So all of the good information that we give them at the beginning. If we think about in terms of compliance, we know that actually children, particularly the children who are 8 to 12 years old, are very good with contact lens compliance in terms of following the instructions for wearing and caring. But they do tend to forget or misunderstand. So revisiting it plenty of times always gives you an opportunity to reset the course if they've become, if they've got a little bit confused or misunderstood something. So we are staying with Mia, but we're changing her outcomes just a little bit. So still the same history. She still arrived back in November 23 at 8 with no family history of myopia, etc. And we're now going to see her again 6 months later after being prescribed myopia control as previously. So it's now May 2024 and she has become minus 150 right and left in just 6 months. So she's got an increase of 0.50 in 6 months. So just a little bit more than we saw last time. So what's your clinical management of this case going to be? So we have a new poll popping up, same options. And I wonder if most of us can predict the responses based on the last response. I'm enjoying seeing these pop in.
Okay, so yeah, answers are coming in. We'll just leave it on for another 10 seconds.
Thank you. So we've just crept up past 60%. So although I think this is probably a good moment to stop that. Thank you. And we'll share those results with you. So as you can see, there's been a little bit more of a shift towards updating the prescription. So that's staying with the current myopia control intervention or changing that myopia control intervention. And fewer respondents saying that they would stay with the same myopia control intervention. So I think that was to be expected, given that we'd seen more change this time. So I will stop sharing those results, or hopefully we can arrange for that to disappear. I think I've done that there. Hopefully for you, there are no results there anymore. So Mia's vision does seem to have progressed a little bit more than we had expected, but it's still within the range of treatment. So let's look at some factors that can impact how the treatment works. So that's looking at wearing times. And in this scenario, we're also going to think about the suitability of the treatment. So what can we do? Can we, at this point, change some modifiable risks? Can we change the wearing time and the wearing schedule? And can we also go back to some of that advice that we had earlier about changing our use of devices and making sure that we increase outdoors time? Wearing times. Now, I've talked about this quite a bit through the session, but this is our slide where we look at this very specifically. You'll notice actually here that I've used the word adherence to recommended wearing times instead of compliance. Now, for those of you for whom English is not your first language, thank you firstly for listening to me speak in English. And secondly, these subtle differences between adherence and compliance may not be relevant to you because you'll have different phrases in your own language. However, for us in English, we're used to thinking about compliance to instructions. Recently, we've had discussions with people in other healthcare fields who are very much of the view that adherence is a better phrase to be using. So as Cooper Vision, we're trying to move away from compliance with wearing times to adherence with recommended wearing times. It's very helpful for us in our industry, particularly because compliance with is very much used to talk about wearing and caring and cleaning and the complications that might be associated with not cleaning your contact lenses particularly well. So adherence to recommended wearing times is our preferred expression. So this is a paper published in let's jump back again. Published in 22. And this is looking at the spectacle lenses with aspheric lenslets for myopia control versus single vision spectacle lenses. And in this paper, they looked at the myopia control efficacy of the spectacle lenses. And what they then went on to do was actually to break it down between part-time wearers and full-time wearers. So their definition in this study of a full-time wearer was a child who wore the spectacles for at least 12 hours a day. And anybody whose average wearing time was lower than 12 hours a day was grouped into the part-time wearers. And there were some very significant differences between the efficacy in full and part-time wearers. Part-time wearers got about half the efficacy for myopia control in both axial length and in spherical refractive error. So it really goes to show that adherence to the wearing times can make a really big difference to the amount of control that we receive. And actually within this study, given that it was a spectacle study where the participants were given instructions to wear their spectacles full time, it might be surprising to you to find that around 40% of the spectacle wearers were in the group of part-time wearers. So they weren't managing to achieve that average of 12 hours a day. So that's 40% of your patients getting, if this were reflected in your practice, that's 40% of wearers getting a less than optimum response to the spectacle wear. So I think revisiting adherence each time is really very useful, and making sure that you choose an option that is actually most likely to be worn by the patient for the required amount of time. And that may mean considering changes with their intervention. So it might mean thinking about, is it going to be easier for them to wear a spectacle lens, contact lens, than it is for them to wear a spectacle lens for that number of hours a day, particularly if they're very sporty. So moving on to scenario 3. This is Mia, again, same as we've seen her before, so I won't go over that hugely, but in this case, she was seen in May 23. So we're now seeing her after being prescribed myopia control in May 24. So she is in myopia control, and yet in that year, she has progressed a diopter in that year, which is somewhat out of our comfort zone for a child progressing. So let's have a look at this, and let's have a think about what our clinical management of this case is. We don't have a poll at this point, but what we do need to do is acknowledge that she doesn't seem to be getting the expected result of slowing from her myopia progression with the treatment. So our first point, personally, I think our first instinctive reaction is to consider a change in management. But actually, I think before we decide on what any change might be, we want to go back and think about her usage of those lenses. So is she wearing her myopia management intervention to the right number of hours? Do her and her family appreciate how important that is? Is this something that might change with an increase of prescription? So being -2, is she likely to wear them more than she did at -1? It's a terrible shame she didn't maybe wear them enough at -1, but maybe that's something to consider. But again, is it the right time to consider a change in management? Are we at this point going to be changing because we believe that another intervention is more successful? And if so, what's our evidence base for that? Because actually it's not conclusive that picking one intervention after a previous intervention is going to actually be more effective. We don't have the evidence for that. So if we're considering a change in management, maybe it is around those lifestyle aspects. There's also the possibility that Mia is a fast progressor. So we actually don't know whether she might have progressed 2 diopters in that year without treatment, and we're still seeing that 50% slowing. And this is one of the ongoing challenges for myopia management and myopia control prescribing. And then there's also that possibility that Mia is a non-responder. So 90% of eyes in the MySight one-day clinical trial responded to treatment, but that does mean that 10% of patients were non-responders. So I think that gives us a few options to consider at this point. I think much of this comes down to availability of interventions in your market and also your own clinical prescribing habits. But I think my point here is to remember that in a recent paper, it was pointed out that the most suitable intervention for any patient is the one that they're actually going to wear. But remember, back to our original slides, what is the most prescribed option for myopia? Well, simply, it's simple single vision spectacles. So you are the patient that is most likely to come into your chair for any kind of follow-up is going to be a patient in single vision spectacles. So that might be a patient that you yourself had the conversation with the patient and parents around myopia control, and they chose at that point not to go ahead. And that could have been for many reasons, but often with parents, it's about this principle of wait and see. One that we think is not advisable, but one that parents sometimes want to go for. Or it may be that they've seen a colleague or a fellow professional who hasn't yet managed to talk to them about myopia control. So it's still Mia. She still came in a year ago with her prescription and found a prescription of -1, and she was prescribed single vision correction. She had the same risk factors. So the poll question here is, if you see Mia in 2024, what do you actually expect her prescription to be? So we'll launch that poll. So she was -1. I'm going to remind you, she was -1 a year ago, and we're seeing her a year later. So getting some answers trickling in.
Yeah. Okay, so we have got almost half of you to have responded.
It's lovely. So remembering that Mia isn't in a myopia control option in this scenario.
Okay, so yeah, I'm sharing the results. Yeah.
Fantastic. So you can see that the most commonly given answer is around -150. So she's a year into a period of no myopia correction. I think that would be, according to the data, probably the minimum that we might see. We're actually probably likely to see greater change than that. But thank you very much for responding, everybody. I will just, there we go. So she is less than 9, and we are likely to be seeing her a year later. So 150 is probably likely to be her change. If she were older, remember that we would see less change. So you can see that at 9 to between the ages of 9 and 11, so she'd gone from 9 to 10, we'd be likely to see under a diopter, and age 12 to 16, it's different again. So I think always bear in mind your patient's age when you're thinking about how much correction they're likely how much progression they're likely to have over time. So she's a diopter more myopic in that time. So what difference does a diopter make? This is a great point to show the parents how much impact there might be on their patients, on their child's vision. So CooperVision on the website have a vision simulator, so you can demonstrate that they'll be able to see close up and near vision tasks quite well, that undercorrected, but actually the distance vision is going to be blurry, and it will help them understand that they are likely to be struggling with tasks at school that involve distance vision. You can also demonstrate to the patient's parents by popping up some plus trial lenses in front of their eyes. I would just say do this with caution, because there are some uncorrected hyperopes out there in the parental population, and I've had the scenario where the parent still sees well with that plus popped up over their eyes. So just, maybe vision simulators are a better example for you. But it is worth pointing out that at this time they are going to have a poorer quality of life. Undercorrected vision is the same as uncorrected lower myopia, and that we know that we would be aiming to correct that prescription. I think a really important point to make to parents is that undercorrection increases myopia progression, and therefore all of the time that their child is spending undercorrected is contributing to that further correction, which keeps leaving them undercorrected. We can also talk to parents about the longer term impact. We know that the risk of myopic maculopathy goes up 67% per diopter, and there's also an increased risk of cataract, glaucoma, and retinal detachment. So progression has both short and long-term impacts. So at this point, it's time to revisit the myopia control conversation. We can talk about the fact that myopia is likely to affect school and sport, and as she's grown, her prescription is growing with her. Special glasses and contact lenses may help slow down jumps in her prescription, which means that she'll spend less time with blurry vision between eye exams. And lower levels of myopia in adulthood can reduce the long-term risk of eye health and vision problems. And so my recommendation at this point for Mia is, due to her prescription, we're going to be recommending again a myopia control option. And it's very important that you consider that carefully. To help you, there are a number of tools out there. So these might be tools for yourself to learn about or to share with the most suitable patients and their parents, in fact. So we talked earlier about the World Council of Optometry. The World Council of Optometry, in conjunction with CooperVision, have launched the Myopia Management Navigator, and that launched really just in the last couple of weeks. It's an evidence-based, up-to-date myopia management resource in one location, and it looks at the 3 key pillars of myopia control, which are mitigation, measurement, and management, and it looks at the evidence base around each of those. So it's primarily designed for optometrists and other eye care professionals to implement the myopia management of the standard of care, and it provides an interactive journey through the 3 M's. but it also is a great tool to share with other professionals in who look after children. So that could be ophthalmologists, general ophthalmologists, pediatric ophthalmologists. It could also be nurses, health visitors, etc. So people that need to understand what the issue with myopia is. And for some parents, this is a suitable resource to share with them. So this is, given that it's eye care professional targeted, it's not going to be every parent, but the parent that really wants to look at the evidence base around myopia management can be directed to this resource as well. We also have Primo. This is a free resource which allows you to look at what the likely changes for children and talk about various aspects of myopia management. And we also have the Occupational resource, and both of those can be accessed through these QR codes. You also have huge amounts of resources available from the manufacturers on their websites. You can also find it on national bodies, other subscription organisations. But really, if you haven't seen all of the OOLS content on myopia management, I would really encourage you to visit the YouTube channel and revisit, because there is a huge amount of content on myopia control there as well. Just drawing attention to the bottom one, My Kids Vision is the parent-facing part of Myopia Profile, and I'm sure many of you are familiar with Myopia Profile and their great summaries of the clinical evidence. So in the last few minutes, we're just going to go through the exit strategy before summarising and hopefully having some time for questions. So when does myopia stabilise? This is a hot topic and one that is particularly relevant as we start to see older myopes beginning to reach that age where we might be considering exiting myopia management. So if you have a look at this graph and you see age at the bottom and you see the proportion of patients with stable myopia here, if you have a look at 15 years old, you will see that around 50% of young people still progress beyond 15 years old. So I think this is particularly important because we could ask what the average age is of stabilisation, and we might be able to use the maths to tell us that's 15 years of age, but that doesn't mean that 15-year-olds are stopping. It means that 50% of them still continue to progress afterwards. At 18 years old, there are still 25% of them still going. And at 21 years old, there are still 10% still going. And actually, I'm sure many of us have seen young adults continue to progress, particularly those in university and particularly those in sort of high demand, near task occupations and courses. In fact, my husband is also an optometrist, and I had a conversation with him just this morning because that's how exciting we are. We have these conversations on a Sunday morning. We had a conversation about a patient of his who is a law student and still progressing through 21, 22, 23. And I expressed absolutely no surprise at that because it's a story that we hear quite frequently. So this information should help us begin to establish when we might want to exit myopia control for our patients. So we've got another scenario here. This is Eva. She started becoming a myope at age 8, a little bit older, and then she became a low myope, and now she is 14. And sorry, I'm just making sure this shows as we expect it to be. You can see her prescription change over time. At 14 years old, she's starting to reach that near that 15-year-old average age group. So what I'd really like you to do is have a look at this graph and then let me know in our last poll what your clinical management of this case would be. So our answers are slightly different this time for our poll. They will be keep going. There are no signs that progression has stopped. Stop treatment and move to a single vision correction, or stop treatment and move to a single vision correction, but monitor very carefully and be prepared to reinstate. So getting a few responses in.
Yep, they are coming up slowly. Okay. Keeping this on for the next 10 seconds and We should be ending the poll. There we go. Yep.
Lovely. So we can see that about a third of you felt that we should be keeping going. There are no signs that progression has stopped. There are just a small number of you thinking that it's time to move to a single vision correction without any concerns. And about 2/3 of you thought that stopping treatment was fine, but we would be monitoring carefully and moving and being prepared to restart if necessary. So we're going to stop sharing those results. And I'm actually just going to pop back to the charts. So this is our patient. She became myopic at around 12, and actually she was really quite stable for quite a long time. We had a very small change, and it's actually really only been within the last few months that she's shown another quarter diopter change. And these are some of the patients where it's much more challenging to decide what to do at this point. She's 14, so she's likely to be not likely to see huge amounts of progression because she's not particularly young anymore. We know the younger patients see large amounts of progression, but she is still progressing. So it may be wise to keep her in that correction and just continue as we had been. But some of you felt that it was sensible to change her to single vision and to monitor carefully. I think by monitoring carefully, you're giving yourself that opportunity to bring her back into myopia management, which I think is wise. So now we have Molly. She was prescribed at 12 and she was prescribed, at 12, and she actually stayed really quite stable till she was 17. Is this patient good to stop? And I think at this point, this is the point where we can exit into adult vision corrections because she stayed really low myope the whole time. She's still going to need some corrections, particularly for distance vision. Another question that we don't really know 100% the answer to is, should this patient still be in full-time vision correction? So this is, again, something we need to continue to look at. So I'm just going to summarise, manage expectations up front and continue to manage those expectations at each follow-up. Progression is expected. Check the amount versus the child's age. Use resources that are available to you to check to see whether you are getting age-matched data on what you should be seeing, both with and without correction. Really do explore all reasons for unexpected progression before you change a treatment strategy. It's unlikely that you're going to change a treatment strategy within the first 12 months. Have good conversations and document them with all eligible children and their families. Assume a young myope is going to progress rather than sort of wait for it to happen and then explain it. And myopia treatment should ideally continue throughout childhood or until the child or young adult shows good stability of their myopia. So I'm hoping that gives us an opportunity for some Q&A. Thank you for listening so far.
Thank you, Katie, for that wonderful and a comprehensive presentation. I think also thank you for sharing all the resources. I mean, that's really useful for everybody on this call, whether it be students or clinicians, to go back and make the most out of these available clinical tools, which not only for your education, but for your patient's education as well, because that's something which we always kind of have a challenge on how are we going to explain patients, and that plays a very important role as well, right?
Yeah. I would agree. And I think one of the long ongoing challenges is knowing that the patients and their parents can only absorb a certain amount of information while they're with you. And so they need something that they can go away and they can read or they can find out more. My concern over a number of years has been that parents go to the internet and they search themselves and they find unreliable sources of information, and everything that's on the internet is true. So it's really important that we're able to send them to good, balanced, well-informed places that they can then find out that information.
Wonderful, great. One question I think, Katie, came in when you were talking about, the scenario number 2, where Mia progressed by half a diopters, and then, we were thinking about in 6 months, and we were thinking that this is where we would want to change and it would be easier if there is a contact lens modality so that you can change the power rather than spectacles.
Yeah.
Somebody wanted to know, would you rather, add on pharmaceuticals with spectacles at that point, if that would be an option available? What's your take on that?
So I think it does depend an awful lot on your availability of those options. And also thinking about the evidence base that you've got for that. I think, again, we may see coming in the future that the combination therapies are more effective than potentially those low doses of atropine on their own. I think it's definitely something you could consider. And again, that's just definitely based on where you are in the world and your availability of that option.
Yeah, I think that's something which you need to look out for in your scope of practice, I would say, right? So if
yes,
you're
yeah,
able
it's all down to that scope of practice, availability, your ability to monitor these patients. Also, I've found over discussions with colleagues in different parts of the world the huge variation in the cost of atropine. And when you have these two interventions and needing to add the cost of these interventions together, that again affects the availability to the patient, even if it's available in your market. It's all about sort of thinking about the most realistic options as well.
right. And I think the next question is kind of probably knowing your thoughts about the case where you have patients who have antimetropia, an 8-year-old who has a +2 on one eye and the -2 on the other eye. What sort of prescriptions would you kind of give? And maybe you could highlight if you would start myopia management right away or anything on that lines.
These are always amongst the most challenging cases for us to answer questions on, and they're challenging because these patients just don't appear in the research. If you imagine that you're setting up a clinical trial, you're going to say, we're looking for patients who have myopia between -1 and -450, and both eyes are equal, and they've got equal vision in both eyes, and they're not amblyopic, and they don't squint, and all of these other things. And you can imagine that this patient would be excluded from that study immediately. So therefore, we have to start making decisions on our own, and those decisions are likely to vary practitioner to practitioner. I think the other things about these questions is we never quite know exactly the rest of the background. So is this patient amblyopic? Are they seeing well with that +2 eye? Is there a reason for that difference in the two eyes? So is this normal, regular developmental myopia in the left eye, or is it actually associated with other visual conditions? So I'm going to be probably deeply annoying and not give you an answer to this question. But I think it's one of those ones to, much as I said earlier, that I think watching and waiting is probably not a good idea. I think in this situation, we might actually want to watch and wait and just see what happens with both eyes over the next 6 to 12 months and see what we want to do at that point. If, on the other hand, if they're amblyopic and they're not seeing well out of that right eye, I think we need to correct that left eye, because otherwise they're not going to be seeing well in the distance. So I think probably given binocular vision caveats on that, I think correcting that left eye is the correct option.
Correct option. Yeah. And I think these are, as you said, challenging cases. Probably frequent follow-ups would give you a better clue on when to start something. So instead of, having them come to you for follow-ups every 8 months to a year, maybe you want to see them a bit earlier and make decisions.
Yes.
Because, yeah, as you said.
I was also going to say, I think we've got quite a few scenarios here where 8-year-olds are coming into us for their first eye examination. And I think all of us would love to see 8-year-olds. So going back to our patient Mia in the scenarios, we'd love to be seeing our patients younger than 8, because we want to know, I mean, first of all, hyperopes are not non-existent. We talk about myopes a lot, but we still would really want to capture those hyperopes at a younger age if there's a risk of amblyopia. So first of all, we need to think about those. Then as we start to see these myopes, we know that the progression is actually most rapid in the year prior to developing myopia. So if we can see patients at age sort of 6-ish and they're less than +0.75 in an eye, we know that they're more likely to become myopic. So actually we can start intervening earlier. or we can start giving good lifestyle earlier. And again, with this patient at 8 years old, that right eye, if this has been around for a long time, probably is amblyopic. So again, let's get kids regular eye exams from a young age.
Yes, that's great. And I think the next question was related to the variation of seasons, and where you mentioned about the progression of myopia is slightly more observed in cooler climates and seasons, whereas the warmer climates and things like that. Would your management strategy change based on the time you see the patient? I'm just trying to modify this question. Let's say you see a patient in the summer versus the winter. Would your thought process of management strategy change, or anything on those lines?
Yeah, so I think if we think about it both in terms of sort of cooler climates, but also in terms of longer versus shorter days. If you're in a country where you have those longer and shorter days, I think you want to think about myopia management over a 12-month period to just get that balance of progression. If you have a country that doesn't have 4 seasons, you maybe don't have that to the same extent. So if you don't have much longer and shorter days, for example, you're less likely to, I think, to see that variation that progression rate change over the year. But I think it's also still important to think about children's height doesn't change linearly. They don't just slowly on a straight line become taller. They also become taller in fits and spurts. So they'll have a big growth spurt where suddenly their school trousers are much too short and swinging around their ankles, and then everything will level off for a bit, and then they'll jump again. So you still aren't likely to see linear progression in myopia, even if you don't have those 4 seasons. So it's still sensible, I think, to look over a longer period of time.
Awesome. Great. So I think that's pretty much it, Katie. Thank you so much for joining us today and sharing the insights, and spending your Sunday afternoon discussing myopia with us today.
As I said, I discuss it all day long with my poor husband, so you've just given him a rest for an hour.
Awesome. Great. So thank you so much, everyone, for attending. We do have session plans over the next couple of weekends. Until then, take care, be safe, and I hope to see you during the next session. Take care and bye-bye. Thank you, Katie. Have a good day.
Thank you. Thanks.
See you. Bye.